Even just stop yourself from face planting walking downstairs, you've got this nerve to thank. So we're diving deep into its anatomy, its incredible function, and why it matters so much clinically. Our mission, give you the essentials, the quick map, so you understand this key bit of wiring in your leg.
Yeah, and we've pulled together some great material, detailed anatomy texts alongside clinical reviews. The aim is really to synthesize it all, to trace its journey from the spinal roots through the pelvis right down to what it does in the thigh, making that connection from the, deep anatomy to quick clinical thinking. That's the real value here for you listening.
Okay, let's get into it then. Start at the source. Where does this whole thing kick off?
Right, the origin, that's the lumbar plexus. It's tucked away deep in the back of your abdomen. It's basically a junction box for spinal nerves. And for the femoral nerve specifically, we're talking about roots from the L2, L3, and L4 spinal segments.
L2, L3, L4. Okay, we hear those numbers a lot in anatomy. Why those three? Isn't there something specific about which part of the root it comes from?
Yes, exactly. That's a key detail. These nerve fibers come from the posterior divisions of those L2, L3, and L4 roots. And that's significant because, generally speaking, posterior divisions tend to supply muscles involved in extension, straightening things out. So originating this way pretty much sets the femoral nerve up to power the main leg extensors.
Ah, okay, that makes the origin story much clearer. And that leads us perfectly to that great mnemonic, doesn't it? The one we found. 2, 3, 4, kick the door. That just hammers it home, right? L2, L3, L4, powering that kicking motion, that big knee extension.
Precisely. That mnemonic is gold, a quick clinical reminder. But before it can do that job, the nerve itself has quite a journey through the pelvis.
Right, it needs protecting on the way down. And it starts off kind of buried, doesn't it? Inside the psoas, major muscle. It seems a bit vulnerable running through a big muscle like that.
Well, it's fairly protected in there, but that close relationship is important. It descends within the psoas first, then pops out along the muscle's lateral edge. From there, it travels down between the psoas and the iliacus muscle in that sort of groove called the iliac fossa. They form a kind of channel for it.
Okay, so down the inside wall of the abdomen, then it needs to get into the thigh itself. What's the landmark for crossing over?
That would be the inguinal ligament, that tough band running from your hip bone down towards the pubic area. The nerve dives right under that ligament to get into the front of the thigh. That's the gateway.
And the second it passes that gateway, as it enters the femoral triangle area, there's that super important relationship, the one clinicians absolutely need to know. Where is it compared to the femoral artery?
Yes, this is critical anatomy. As it enters the thigh, the femoral nerve is always consistently lateral to the femoral artery, side by side, but the nerve is on the outside.
Lateral to the artery. Okay, so if you can feel the pulse of the artery.
You know the nerve is just next to it on the lateral side.
And that's huge for safety.
Yeah.
Right. You don't want to be sticking needles in the wrong place, hitting the artery instead of the nerve during a block, for instance.
Exactly. The artery is your reliable landmark. And once it's past the ligament, the nerve actually doesn't travel far before it splits. It quickly fans out into its anterior and posterior divisions to cover the front of the thigh.
Okay, map established. Now, the function. We know kick the door, knee extension is the big one. But break down the motor control for us, starting up high and working down.
Right, the motor function. So even while it's still up in the abdomen, it gives off branches to the iliacus muscle. That's a major hip flexor, helps you lift your thigh. Then once it's in the thigh, the anterior division takes care of the sartorius muscle. That one helps with flexing and rotating the hip outwards, important for sort of positioning the leg.
But those are more like supporting actors, yeah. The main event, the powerhouse, is lower down.
Absolutely. The main engine is driven by the posterior division. This division innervates the quadriceps femoris muscle group, all four parts of it. So the femoral nerve is basically the sole command line for knee extension. Standing up, climbing stairs, kicking, that's all quadriceps, powered by the femoral nerve. If the nerve's out, the quad is out. Simple as that.
Okay, motor power covered. But then there's this sensory side, which I find really fascinating. It covers quite a bit of ground, doesn't it? Where do we actually feel things because of this nerve?
Yeah, the sensory map is pretty extensive. It starts with some smaller branches from that anterior division supplying skin on the front of the thigh. Pretty straightforward. But the long-distance runner here is the saphenous nerve. This one comes off the posterior division, and it's the longest sensory branch of the whole femoral nerve.
Longest, meaning it goes way down, past the knee.
Oh, yeah, way past the knee. It runs down the inner side of the leg, often alongside the big vein there, the great saphenous vein. It provides sensation to the whole medial side of the leg, down towards the ankle, and sometimes it even reaches onto the medial side of the foot right up to the ball of your big toe.
Wow. That's quite a territory. So theoretically, a weird feeling like pins and needles at the ball of your big toe could trace all the way back up that saphenous nerve pathway to the L2, L3, L4 roots. It connects the foot to the low back.
It really highlights the connection, doesn't it? And just quickly, we should mention the posterior division also sends little branches, articular branches, into the hip and knee joints themselves, giving feedback on joint position, proprioception.
Okay, so it feels the joints, it moves. That makes sense. And this all leads perfectly into the so what? Why does knowing this map L2, L4 origin, lateral to the artery, quads, saphenous nerve, why is this so crucial, especially for anyone in, say, healthcare?
Well, knowing the geography is vital, both for spotting problems when things go wrong and for using that knowledge to help people, like with pain relief. Let's talk about injury first. Because of its path through the pelvis and under that ligament, it's definitely vulnerable.
What kind of things tend to damage it?
Things like major pelvic fractures are a big one, but also, unfortunately, sometimes during medical procedures, iatrogenic injury, maybe during a complex hip surgery, or sometimes related to accessing the femoral artery for things like heart catheterizations if care isn't taken.
Right, and when it is damaged, the signs are pretty clear-cut, aren't they? There's that sort of classic triad of symptoms. If someone presents with this nerve injury, what are the big three things you'd say? Okay, number one, motor loss. Massive difficulty with knee extension. They just can't straighten their knee properly, can't push off. The quadriceps muscle is weak or paralyzed. Walking becomes very difficult, unstable. Number two, reflex loss. The patellar reflex, the knee jerk, depends entirely on the quadriceps firing when the tendon is tapped. If the femoral nerve is damaged, that reflex arc is broken. So loss of the patellar reflex is a huge sign pointing right at L2, L3, or L4 involvement via this nerve.
That's a powerful link. The simple tap test immediately tells you something's wrong way back at the nerve root level or along the nerve itself. What's number three?
Sensory changes. Numbness, tingling, what we call paresthesia. You'll find that over the anterior thigh and, importantly, all the way down the medial side of the leg and sometimes foot because the saphenous nerve is affected too. So quad weakness, no knee jerk, and numbness down the inner leg. That's your femoral nerve injury triad.
That really crystallizes it and makes diagnosis much faster. But let's flip it using this anatomy knowledge for good. The femoral nerve block. Yes, the femoral nerve block is a cornerstone procedure. It's done all the time because we know exactly where to find the nerve. It's fantastic for pain control, especially for things like femoral neck fractures, broken hips, which are incredibly painful, or for providing anesthesia for surgeries on the knee or the front of the thigh.
And let's just reinforce that key landmark again. For someone learning this, doing the block, where are they aiming?
You find that femoral artery pulse, just like we discussed. Then you go just below the inguinal ligament and just lateral to that pulse. That lateral to the artery detail isn't just trivia, it's your safety guide. Keeps the needle away from the blood vessels. It's using the body's own landmarks.
Okay, so pulling it all together, we've got the L2, L4 roots, the path through psoas, popping out lateral to the artery, powering the quads, feeling the front and inner leg. What's the big picture takeaway?
I think the main thing is that this nerve is fundamentally about stability and movement for the lower limb. Knowing its L2, L4 origin, its relationship to the artery, and its absolute command over the quadriceps, that's your key to understanding function and dysfunction. It's the nerve that lets you stand tall and straighten your leg powerfully.
It really is crucial, isn't it? Something most of us take for granted. Every time you listening, take a solid step or climb some stairs without thinking, you're relying on this whole intricate system firing away from L2, L3, L4. It's quite amazing when you stop and think about it. And maybe here's a final thought for you to chew on. We talked about that super long sensory branch, the saphenous nerve going right down to the inner foot, maybe even the big toe. Now consider this. If someone has persistent weird numbness or pain just on the medial side of the foot or ankle, how quickly should we think beyond just a local foot problem? Could that symptom actually be a signal of something happening way further up the line, maybe the nerve getting pinched near the spine or in the pelvis? It really shows how interconnected everything is from your toe right back to your L2 root. Makes you think, doesn't it?